So we're now recording. We're back to our call with Dr. John Burgess, DO from Shenandoah Integrative Medical Clinic and one of only 5 certified registered pain clinics in West Virginia. And we have a couple questions after Dr. Burgess's presentation. And I'm just going to cover those questions, and then we'll ask Dr. Burgess to comment on them. And I believe some of them he's going to throw back to us if I know him.
Yeah.
Anyway, the first one is that are there non-addictive drugs that can be considered in lieu of some of the opioids that are being used? Secondly, if so, how can we get that to the medical professionals? And thirdly, because the addiction is profit-driven to keep them addictive, how much is that affecting the addiction problem? And I just want to make one comment that he explained to me, which really shook me, which really made sense from what one of our participants had shared in a previous call. They've been using opioids because tremendous herniated disc issues in their back, and they have to take them on a daily basis, but have been taking them without an addiction problem. What Dr. Burgess explained to me in his clinic, and maybe you can comment more about it, he said an opioid taken in the right micro amounts can be very effective for pain, but it does not become addictive. The problem is if you get more of it, where you go beyond that minimum amount, then you start getting this experience of the endorphins in the body and all the cacophony of things that happen in the body and the hormone system, which you now become addictive. It's the extra amount you begin to take, and as you do that on a regular basis, you now become addicted to the feeling you get beyond the pain. So you start with the pain, but then you go into this other level of mind-altering characteristics of the opioids. But with that said, I'd like to turn over to Dr. I'm sorry?
Talked about dependency in between addiction. Very important word. It's Dr. Burgess.
Dependency versus addiction. Okay.
Very big difference.
Yeah. So
That's what it's all about.
Right. So go ahead, Dr. Burgess.
Okay. Well, first of all, we might as well define what's the difference between dependency and addiction. Dependency is just something that physically happens. If you take an opioid for long enough, your body will crave it. It's just the way it is. Your body becomes tolerant to it, so it usually needs more drug to have the same type of effect. I'll say, but the same type of effect mentally. If a person takes an opiate because they like the mental rush, buzz, maybe moment of clarity that they might get with the opiate, if that's why they're taking it, for the joy of what it does to their brain or the physical pleasure they get from it, then there seems to be a much greater desire to take more when you talked about microdosing and dosing. If you're taking the opiate for pain, it does not seem to get the person high. It does not seem to affect them mentally. In other words, if this person has a gallon of pain and they take the medicine, they do not seem to have that same type of euphoric experience that they would if they don't have pain. But if a person takes the opiates when they don't have pain or a specific pain, a physical pain I'm talking about, then it affects the mind much more greatly. And if you're taking a certain amount, say 10 milligrams 4 times a day of oxycodone, if that's what you're taking, but you're taking it for pain, you could probably take that for the next 20 years and not see a big rise or increase. You might be able to take that 10 milligrams 4 times a day for 20 years and never increase it. And it's very strange, but appears to be true with everybody that I've seen so far. But again, if you're trying to take it for some euphoric reason or a rush or a pleasure, then you're playing on thin ice. Then all of a sudden the dose tends to increase twofold, fivefold, tenfold. And you don't usually see that if you're trying to treat pain. So basically, if the patient is sincere in trying to treat the pain and they understand, they can differentiate between pain and sadness, loneliness, rejection, withdrawal. If the patient understands the difference, it's much, much easier to actually use the opiate. But if the person doesn't and they're chasing the drug for the wrong reason, the euphoric high, it doesn't take any time. Within a month, you could be living in hell and be very seriously hooked. So anyway, if you have pain, it's not as much of a problem. If you don't have pain, now you have a big problem.
Great, thank you. Dr. Burgess, so then with that understanding, the issue which we talked about, non-addictive drugs to be considered, doesn't seem to be as much of an issue as managing the proper dosage of the drugs that are being used. Is that correct?
Are you saying managing appropriate use?
Yes, managing appropriate use
if you
is more fundamental than trying to find some non-addictive solutions.
I would say that's true only because God created the mu receptors in our brain for pain, in our entire body for pain. And God created a plant, an opium plant, which seems to connect with these mu receptors to turn off the pain. And what you're saying is quite true. If we are using opiates as bad as they are, and they have such a bad reputation, we have to remember that the opiates do not destroy the kidneys. They do not destroy the liver, don't destroy the heart, don't destroy the brain or the lungs. So there are many, many beneficial aspects of the opiates that you do not get with the alternative medications. For instance, Tylenol has dreadful consequences on the liver, destroys the liver. Something as simple as Advil, the ibuprofen, and a lot of the anti-inflammatories kill the kidney. So they are, as far as the person's life expectancy, you'll live longer on the opiates than you will on Tylenol.
But would you say the opioid epidemic is not really that the opioids are so evil or so bad, but it's the abuse of them which drives us into the addiction situation, which is maybe driven by profit either on the street with the heroin epidemic or even in the medical community, the sale of opioids from the medical profession. So is it the profit that's pushing the overuse, which is creating the problem? Would you say that's the more bigger driver?
I say the lack of education, the ignorance, confusion is the big driver for the overuse, for the abuse. If the patient understands what the medicine is being taken for, and they have a clear understanding that it's used to not just make a person feel mentally better, but we look for the word function. If you have a person who cannot walk and they can take an opiate and walk, they can't play piano, they can take an opiate and play the piano. They can't wash dishes, they can't take a shower, they can't even get out of bed. So these people, if they look for function, not do I feel better, then you see a much more realistic association with the drugs. And then the patients have much more control, understanding of it, and they really don't tend to get into trouble. I mean, before we started pumping up and you talk about dosage. The dosage before 1995 for the average elderly person who might have the arthritis, aches and pains, or some type of physical trauma, the average dosage would be maybe 5 milligrams. So they could get by on this for 5 to 10 years, taking 5 milligrams every 6 hours. When we shifted into the new drug world with OxyContin, the dose went from 5 milligrams in one tablet to 160 milligrams. So all of a sudden, instantly, the doses were going from 5 to 10 milligrams to 160. So you could take 5 to 10 milligrams 4 times a day and never have a problem with it. You're not going to die. You're not going to have respiratory suppression. You're not going to die. You're not going to stop breathing. If you take 32 times the dose, yeah, now you have the problems, and now you have the addiction hook getting wedged much deeper. So it wasn't a matter of just the type of drugs we were shifting to in the 90s. The dosages were drastically, unbelievably raised when there was no sense for that. That was just dangerous, crazy, and yes, it was profit driven. And I think there are two things, because when we talk about the profit and how it's involved with the addiction process and our crisis now, two things are involved. One is the ordinary profit of the person who's trying to sell a few pounds of some drug for $100,000 or $1 million profit. That's kind of raw financial profit. But other than the simple profit off of these drugs is the word control. Some people at higher levels of government, world control, banking control, they're really not so much interested in profit, money profit, as control itself, where you start controlling a society, a group, and do it through any method. So drugs might be used to control a group, not just to make money off that group, but to keep them stupid, keep them hooked, keep them cute, confused, and as one friend repeatedly says, keep them distracted. So if you can dump heroin in a community, crack cocaine in a community, it's much easier to keep those people ignorant, ill-informed, and unaware. So I think part of the process for some people who are dealing with these issues of massive opiate transfer, drug transfer, it's about population control.
The buzzword today, Dr. Burgess, is that you're on the farm or the plantation, is it not? They
Say
keep them
that
on
again.
the farm or plantation.
Yes. Well, I heard a black guy talking tonight at a college, a conference, university conference, and he started speaking intelligently, and he said, "I'm off the plantation, bro. I'm off the plantation." So he has the right to think, and he can think, but there is so much propaganda, mind control, so many efforts like this, that the drugs just become a tool, not a tool for profit, but a tool for control. And I think that's another issue we need to look at, because if we're going to be making a real effect or making real changes with this, and maybe not, we have a clergy and our community leaders in this group, and that's great. But then we have politicians, and they might not be clergy, and they may have no concern whatsoever for their constituents. So when you get into the political realm, now we have the congressmen, the senators, and the FDA and the DEA and the CIA. You're dealing with control issues more than profit. If you get into the guts of this thing, and then when you can get an entire country involved in this type of process, either cocaine or heroin, you just watch the whole country be destroyed. So it's a way of taking down a country. And but usually when we are trying to make changes through the politicians, they are so controlled by the banks, by their leaders, the people who tell them what to do, that there's really no significant change. And that's why over the last 20 years, we have seen the crisis become worse every year. It's not improving. So we have to do something different.
I want to mention something what you're saying, Dr. Burgess, is very significant, because to step away for a moment from the heroin cocaine aspect, and we start out with the oxycodone and the oxycontin, and increasing the dose to amounts that create all the damage and the addiction and the dependency. And you said it's education, it's understanding.
Yes.
So it seems like if you work on a campaign for the education, and through churches, through community groups, you talk about, look, the use of these drugs in their proper amount is not bad. I mean, there may be ways to do other things, but if they're kept in small doses, and then encouraging the people to bring down the dose, because if in fact the money-driven issue of the politicians, the drug companies who fund the campaigns, all dealing with that big problem, but maybe in a local community, if we could get the educational material, maybe people could learn to manage their dosage. Now, I haven't stepped into the cocaine heroin aspect, because that's another very important component that may be driving the community collapse, because it, as I understood, some people may start off with these approved drugs, but then end up going to these illegal drugs, and then that's of course where there's no control, and they're going for all the wrong purposes. So would you say education and human communication can be a big component, and also the need to change their mindset and take extra amount can be because the breakdown in the family, the breakdown relationship, and they're so lonely and heartbroken, they don't have a solution, so they just want to take more and more drugs to at least dull the emotional, the spiritual pain. So one is the actual medical education, the other is the human relationship side. Do you think those two aspects would be something you can work on to begin to make a change? I mean, we have to make the bigger change with the politics, but what can we do locally?
I think that's where your answer is. If there's going to be any positive response to this or any real progress, it's going to be decentralized. It'll have to be education, but education through our families, education through our communities, education through the church. If you're waiting to be educated from the top down, if you're waiting for the federal government and Purdue Pharmaceuticals and the FDA and the CDC to educate us, we aren't going to be educated. They've had an opportunity to educate us now for 40 years. And instead of information, we've had misinformation and a lot of lies for at least 40 years that we know of. The government knows full well what these drugs do. Even the drugs like the Ibogaine we mentioned, the government knows about these drugs. They studied it, they researched it, they know what the answers are. But they're not telling the truth, and maybe profit has something to do with it. But we're talking about big bucks in control. We've been asking all week in our office, who do the politicians, why do the politicians make rules that control us? Why are the politicians making rules about medicine, about opiates? Who are the people that are educating the politicians? The laws are affecting us, but who is educating the politicians?
Exactly.
It's not doctors.
Right.
It's not physicians in the know. It's not the specialists.
Money.
It's
The drug company.
it's the insurance companies and drug companies and the banks who control the drug companies and the insurance companies.
Right.
They are the only ones who are telling the politicians what to do. Politicians, if they were to become educated, would know about Ibogaine and almost none of because it's the best treatment in the world for getting people off of opiates. And so why don't they? Who are the people that are educating the politicians? And maybe educating is not a good word. Who are the people who are telling the politicians what to do so they can get their appropriate campaign contribution and their child can get their scholarship to any university they want? So I think that's where our big problem is. So if you're looking for the answers for the people at the top, such as the politicians, they're already sold out. They're gone. They haven't been doing things in our community's interest for many years. And right now, with the lies, the cover up, and the continuance of the policies, these policies are more distractions. They're not working at all. So I think in order to have a successful education of the community, of the kids, of the population, it's going to have to be on a grassroots level. And that means the churches, with their ability to communicate and share, could probably do more to educate the youth and the people who are in this situation than the government. And I mean, I can tell you guys a secret, all right? Here's the secret. So people think that our government is trying to find an answer to these problems. They are making rules. They are making laws. They are making restrictions. They are making prisons. And they're putting lots of people away. Now I forgot what I was thinking about. The prisons threw me.
We're talking about the government, and you start to branch out into the prison systems and other avenues, secondary avenues.
The secret.
All of the things they're doing are not getting people off the drugs. All of the methods they have are not getting people off the drugs. And we could name a whole bunch of drugs, because we're just talking about opiates, which is my pain specialty. But if we talk about the antidepressants, the opiates are a drop in the bucket.
Tip of the iceberg. That's right.
The tip of the iceberg.
SSRIs are the worst.
You got it. So the number one profit-making drug sales in the United States is not even opiates. It's antidepressants. So our government is pushing the antidepressants. Now the government, the federal government, is insisting that pain management doctors give antidepressants to their pain patients. In other words, put them on another drug. And then you have the anti-anxiety, then you have the sleepers, then you have the muscle relaxants, and you have the bipolar medicine, and you got a mess. You got somebody who has lost their mind and probably their own soul by that time. But
So
that's what
Can I share something?
yeah.
Okay,
Yeah,
so
we have
Yeah.
10 minutes, so go ahead, Lewis, and
I just want to say this one point, because I don't want to interfere and take away the time. Most of us on this line have been educated that money, power, then knowledge, in that order, are the three motivating factors of all humanity. And I gotta say that the people in power, they're in a fog. Okay, the money people, they're motivated because they're greedy, and they probably had a good idea in the beginning and probably were very idealistic in the beginning. But when they start to get Midas's touch, you get a little greedy. And the people of power, they can only think about so much at one time, you know, and because we're just human beings. And the people of knowledge are the bottom, because they don't make people of power and money are not concerned about people of knowledge. They don't have enough respect for new understandings. They're not open to a new understanding. They're too comfortable living in their power, becoming kings of the earth, or if you will, and those who have great resources at their disposal. You know, it's just that simple.
Great, thank you. That's true. I want to we have about 7 minutes remaining. And I think actually Dr. Burgess has come up with, I believe, some very substantial things of what we can do in our communities and help others with. He talked about its education and relationship, both education for relationship and even medical education. So health freedom is needed, and local. Don't depend on the state. Don't even depend on the whole city. Just think about your neighborhood and educate there. And the ways that we can educate, one would be your small local pharmacies are right there living in among the people who can understand that and would be willing to, you know, maybe be educational centers. I'm not talking with big mega pharmacies. The small pharmacies are going to all kinds of natural and integrative things. That would be one option. Another option would be like this call, a Zoom call. Invite a doctor to be on a call once a month where people want to learn about the proper use of drugs and what websites they could go to learn. So when they go to their doctor, they can say, Doc, look, I want to go back to 5 to 10 milligrams of oxycodone. You know, I want to do this, I want to do that. Some advice on how they can go, and they can do their own research, but have a place where they could speak. And you could have two types of Zoom calls. One Zoom call could be only with those who have a dependency issue, because there's a little bit less stigma. They're all in the same situation. You know, we have some people on this call who do have a drug issue, and they can be very understanding, but most of us don't. So it might be a little bit shy. Or you can have just a general open session. And we leverage technology to be used for the good. And the third can be communication in churches and community groups, where you can come in and a medical professional, you make a PowerPoint on it, where, you know, someone who's not a medical professional but can share the data, and maybe have a group of websites they could go to learn for the proper use. We're not dealing with the mega street problem of cocaine and you know, heroin in that, and that's another issue. But if from overuse from their doctor pushes them into either all these other drugs from the doctor or even into street drugs, then, you know, what do you think of that is a beginning point that we can start to work on to at least make some progress, focusing on the area of education?
You had mentioned money and was it money, power, and knowledge?
Yeah,
Okay.
Dr. Rabbi mentioned money, knowledge, and knowledge.
Yes. Okay. Well, and you had mentioned that knowledge was on the bottom, right?
Right.
But what if there is some way through this community education well, how can we put knowledge on the top?
Right.
Because
exactly.
basically we have not been telling the truth. So how can we get I'm asking, how can we get knowledge on the top?
Well,
could that be done by having a decentralization?
Yeah.
Well, what do you think of what I suggested?
Well, he asked a question. And,
sorry.
And didn't you just ask a question? Or is it being rhetorical for the moment?
Pharmacy's not going to. It's not going to happen. The small local pharmacies, I think you can almost forget that, because they are so intimidated at this moment by the DEA. They're not going to say or do anything because they will be hit hard.
Right.
They're going to go along with whatever DEA policy or attitude there is. Otherwise, they will be wiped out. They will be taught a lesson. So I don't think the pharmacy education is going to work. You might have pharmacists that lecture within the religious or church system, but if you're dealing with pharmacies or the pharmaceutical supplies, it's not going to get anywhere.
Okay.
Because even the government that deals, the DEA that deals with the drug investigations, they aren't even aware of who's selling the drugs, who's involved. McKesson is the largest drug pharmaceutical distributor in the United States, and most of the people in the DEA had never heard the word, never heard of the company.
They're in a fog.
So they
Okay,
really,
so then,
a fog, yes.
so maybe the other two options. What do you think? Zoom calls for people, medical professionals, can come on and learn and grow and be guided to certain websites that might be good for further study on their own for their self-empowerment. It could be members of their family to help them, if you know. And then the other one would be community communication, churches and community groups, where you could maybe invite a pharmacist who would maybe speak there.
I think one effective.
I like the idea.
Go ahead.
I think one effective thing that we can do immediately is if Dr. Burgess, if we can put all this in a nutshell, just a little pamphlet and distribute just freely, just giving pamphlets here and there everywhere, and putting in every mailbox, on every home and every hand, some information how to get out of this addiction, you know. And I think Dr. Burgess, he mentioned about this drug that they can, I don't know where they can take it, one pill, and they can be free. But some information so these people can know the options that they got, because many people don't know. Today, I was enlightened on what Dr. Burgess says, and I'm very excited about this pill, and I just want to see where you can get it, how you can get it. I think it's.
I can answer that. The ibogaine is not legal in America.
Oh.
And so you have to go to Bahamas or Mexico, or Canada's kind of an iffy place. There's Costa Rica and other places, but it's not legal in America.
That because of the FDA?
Yes.
Yes.
Well, go without saying. They control things.
So the first thing to do is to try to get the politicians to start to, you have to educate them about it to get it in here. The churches have to be really, and the organizations have to be the ones to really administrate it, because the medical community is not going to do it unless it's alternative medicine groups.
But